there's a lot of anxiety at the investor level, and in the biotech companies, it's a topic at board discussions, you know, almost in all companies, that industry is accustomed to taking big financial risks and big scientific risks, but that they don't really want to multiply that by the lack of certainty of healthcare reform. And specifically in the ACO model, how would you allay the fears of many in the industry and investment community concerning any potential negative consequences for medical technologies that are more costly up front, yet have long-term cost savings with better patient outcomes?
Sure. Sure, I'll take a crack at it. I mean, first let me make a comment about ACOs or ICOs. I don't think anybody at this point, the governor's bill hasn't. I don't think our bill will. There's no mandate that happens. I think that our goal in government is not to preclude innovation. You may have a better idea for how to integrate services other than an ACO. That is the topic du jour, but that doesn't necessarily mean it's the best model. I know that the Secretary has appropriately pushed patient-centered medical homes. We've talked a lot about behavioral health medical homes. There are a number of options. I think that what will happen with innovation in the industry is that if we are operating under a global payment, there is this idea that things are going to be capitated and things will be limited. I think exactly the opposite. I appreciate Lynn's comments very much, and I think that the point of that is that if her physician is ordering something for her or a patient, then there would be no dispute under an ACO. There'd be no dispute. It is the third party often that we fight with now. But because we don't have that relationship with our physician or our doctor to be able to make those decisions together. So on shared decision making, I don't foresee patients having that issue. Now, in terms of the industry, when ACOs are making purchases, they're going to be purchasing things that work. They're going to be purchasing things over time. So the difficulty for the industry is going to be to make those investments that seem like very good bets. That is really, I think that at the board level, what boards are going to have to do is spend more time doing due diligence and trying to find out what works. We're never going to hurt a company in Cambridge that's making extraordinary changes to cystic fibrosis treatment. Why would we ever hurt that? That makes perfect sense. We're never going to hurt your company that has been adding jobs to our market and been so successful in this marketplace and doing extraordinary things over the last 10 years, I think, since we first met. It is going to be those that have been taking research money without coming up with a product, or when they come up with a product, the product doesn't work. Now, that's all a little bit difficult, I think, to quantify, but there will be research money available. We've talked about, after 3 years and seeing where the market is, making money available for research if there is, if we have fallen short in any particular area, so that we make sure that innovation continues. And it might have to be direct research grants, but we think that government should be your partner in doing that and continuing to do that.
I want to emphasize Chairman Walsh's response related to who is the decision maker here. And in the governor's vision for how this plays out, we're not talking about the managed care gatekeeper system of the late 80s and 90s in terms of controlling cost. That was managed cost, not managed care. And we believe fully that the care should be delivered within the provider system in partnership with the patient, and the decision about what drug should not be based on who the payer is. So we're in accord on that. We believe that with the type of system we're suggesting, that providers will have more flexibility, not less flexibility, and they will be able to determine what is the best treatment based on the outcomes for their patients. In terms of forecasting where the industry should be looking to promote products and seek investment, I think that there's a parallel to what is happening at NIH and at other places along the lines of translational medicine. We really believe that innovation is very important. As I said, we believe that by containing costs, more people will be able to afford new prescriptions, not fewer, and be able to afford drugs that, because of the investment and the R&D, will have to be more expensive in the beginning. And this is true of other advances as well. What we're asking the industry to do is partner with the healthcare system, to partner with government, to be able to demonstrate the value of that investment and to work with us to say, we know we're getting better outcomes, high quality, improving patient safety, making the lives of people better. And that's what we want to pay for. So if those are goals that we can all agree on, I think that the investments have to be there.